Hi, I'm Dr. Gulani. I'm a chief surgeon and founding director of the Gulani Vision Institute in Jacksonville, Florida. Today I'm going to talk to you about how I use the OPD-3 in my practice, what I call and teach all the time. I call it art of vision surgery, which basically means how you apply all the aspects of refractive surgical techniques in our armamentarium, including technologies, to design a surgery for each patient to the best vision potential they can achieve. So in my practice, which has a unique blend of patients who not only come in for virgin eye surgery, which may be myopic, astigmatism, presbyopia, cataract, there are also a category of patients who come for second opinions and complication correction. I approach every case as a unique situation, not as a complex scenario. And when you approach cases like that, it makes things very simple. It doesn't intimidate the doctor or the patient, and pretty much you get to work coming up with a plan that unfolds in front of your eyes. The plan actually unfolds after the investigation is done, which is, let's say in this case, a patient comes in with any case scenario. When you do the OPD-3 testing, the efficiency of the technology allows me to get the refractive error, keratometry, spherical aberration, pupil size, angle kappa. All of these data then allow me to decide what in fact is causing the vision complaint that the patient has. Which element of our optical system is causing that complaint, so I need to direct my attention to it, and how many elements do I need to correct? So shortly I will share with you a few case scenarios where we'll go over these concepts and how you come about it. But talking about technology, I think the need of the hour has been and was something like an OPD-3 that would bring in all this data in one platform. So a patient sitting at one single station, we can detect all this information, take it to us in the consultation room, show the patient on screen what exactly you're seeing. Is it the cornea that's causing the impact of poor vision? Is the premium IOL the source of glare, or is it the astigmatism residual in the cornea? Is the patient's visual capacity affected from Lasik ectasia, keratoconus, impending cataract with keratoconus? And therewith, you come up with a plan of correcting each element in single or staged concepts to excellent vision. Let us look at some of the cases now which were referred to me as complex, difficult, complications, whatever you call it. And my trend is always to look at each case as, well, let's solve the mystery here. Let's see what's going on, and yet don't give up on the conscious effort to always aim for emmetropia. So let's take our first case scenario here. For example, this patient was flown to me with following a PKP long time done on this patient, beautifully done. The patient had cataract, high myopia, high astigmatism. Now, when I looked at this patient with the OPD, I could see the cornea had some impact on vision, meaning the cornea element has to be addressed. At the same time, the cataract was a major player in decreasing this patient's vision. Now, associated with the cataract, that's how I like to think all the time, this patient also had refractive errors, high myopia, astigmatism, presbyopia. So we take this patient in his non-dominant eye and perform a toric lens surgery. Having done that, you can see why this patient is thrilled with his outcome of 20/25 vision next day. And you can see the pre-op and the post-op OPD reading, and you see the quality of vision has improved tremendously. Even though this patient could see great with hard contact lenses before, the quality has changed immensely just with the cataract removal and correcting the refractive error with the toric lens. So the OPD here helped me decide what to do. I can also confirm what I did because the toric lens, as you can see, is sitting exactly on the axis I want. You can see it in retroillumination, and you can see it in the OPD picture of retroillumination too. And also it helps me decide, why is this patient happy when I'm not happy with the cornea the way it is? And you can see that the element of the cataract and refractive errors were corrected, impacting vision to better outcome. And if you see the same patient in the next slide, you see here how the OPD shows us that the visual quality is poor with this transplant. But overall, total OPD of this patient, including the cornea, is actually excellent. So overall, the patient, despite that transplant, is seeing 20/25 and is thrilled with his vision and the freedom after so many years. So I would again like to reiterate, you're using the technology to first determine your plan of action, to determine did you execute correctly, meaning you're confirming it, and 3, you're then looking at why exactly is this patient happy, and if not, what can you do to address it? So if this patient was not happy because I saw that the cornea had irregularity from his transplant, I would have done a laser surface ablation on this cornea to further improve his visual quality, again guided by how much of that is affecting the patient in his vision. And now let's go to another case. Here you see these patients who present to us now with having had RK surgery, cataracts not that dense yet, around 20/40 vision, but they're not happy with the quality of vision. A lot of doctors go looking at this, say, okay, wait, let your cataract mature. Remember, these are active people. Plus, these are mostly type A personalities because that's why they had the RK surgery as early adapters. So you have to listen to their complaint and take it seriously. So in such patients, what you would do is you would go ahead and do their cataract surgery. Again, I never shy away from what technology I need, because no matter how difficult the case, our goal doesn't change. Our goal being emmetropia, despite the complexity of RK. So here again you see I went ahead with the toric lens, and you can see the position of the toric lens I'm checking after surgery. And you can see the alignment on the OPD retroillumination, including clinical retroillumination. So we got the lens right in place. And this patient is at 20/20, but coming just from 20/40, your question could be, why is this patient so happy when they weren't really that blind? Look at the quality change that you can document with the OPD here, the pre-op and the post-op. You have those total OPD readings, and you can see how clear it is post-op. So these patients, even though they're not 20/80, 20/100 bad, just taking them from 20/40 to 20/20, despite their RK, you're still taking them to excellent vision and able to document why they are happy. Let's look at another case now. So these are patients of corneal dystrophies, scars, and as you know, I treat them with laser corneoplastique concept, meaning you clear the scar using laser PRK, and then if needed you can do intraocular surgery if they had cataracts, correcting back what I call manipulating their optics to excellent vision. Here again you can see RK case with scars where I planned 2 stages, but based on the OPD's severe deterioration in vision, you first do laser to clear the scar. Now I'm planning an internal OPD on this patient and planning for a lens surgery to take them to as close to emmetropia I can. Here is a pretty bad scar, as you can see. Not only is it a scar, this is a herpetic scar. You can also see a divot in the cornea, meaning the cornea actually has lost some tissue. You can see that tongue-shaped scar with excavation in the center. Now, of course, given the history of no recurrence, my plan using corneoplastique principles is, yes, this patient can have a transplant, but let's first do laser. Now, with this patient, I basically went ahead and did a myopic ablation laser, again with principles of corneoplastique, and you can still see the scar post-op, residual. But the beauty is, why was this patient happy? So coming from a vision of 2400 best corrected to 2050 uncorrected, despite that scar with excavation, following just a minor laser PRK technique, this patient is thrilled because you can see the OPD down right there, pre-op and post-op. And now you can actually quantitate why this patient is thrilled, because to me, he's still not 20/20, he's 20/50. But he's thrilled beyond belief because his quality improved. And you can also confirm that with technology using the OPD and say, okay, now I understand why you're so happy. And from here, you also understand another element in this gentleman, because he was in his late 50s, is maybe down the road he'll need cataract, and that internal OPD is something we'll tackle at that time. Going to another case. Here are patients with INTACS where you can plan the entry so well now that you can literally manipulate the shape of the cornea going in with the INTACS. Remember, INTACS are not just to be put into the cornea to arrest the cone, if you may, or flatten it. Take advantage of the fact that with INTACS you can actually use a thicker and a thinner ring. You can make a superficial and a deeper channel, manipulate the whole cornea with that one opportunity you have, and shape it up. And patients do achieve vision of 20/20s. It is possible. So the planning is very important. If you look at this OPD of the patient pre-op and post-op, you can see pre-op this patient with an RGP contact was 20/25. So, but with just INTACS, without contacts, you can see the severe improvement in quality and why this patient is very happy. And of course, the vision reading was uncorrected 20/20. Again, another case here. You see this patient had a pseudomonas ulcer on the cornea, was sent to me for transplant, and as usual, I always try to resist a transplant to see if we can do the least intervention for best vision. So in this case, given that the tissue was very thin, I didn't plan laser, but I thought, how about if we put an INTACS into this cornea? By virtue of law of optics, we are stretching the scar, and but also we are not affecting the thin center. In fact, we are strengthening the remaining cornea. So by doing that and the corneal scar getting automatically stretched using INTACS in this case, here is this patient thrilled and happy with his vision. And with the OPD, you can understand why. So again, you see the pre-op vision, very blurry, distorted, and post-op vision, and all he had was INTACS. And the scar is still there, of course, residual scar. In fact, you didn't do anything to the scar, just stretched it. And the cornea being thin is no issue now, because just like keratoconus, you have stabilized it using rings like braces in the periphery. So this thought process of designing surgery for cases, no matter how complex, unique, or difficult, and taking them to a self-designed surgery to the best emmetropic, what I call best vision potential outcome, I think is the need of the hour. The OPD-3 gives me a lot of the information that I need to discuss with the patient in the room why I came to this plan, and then decide with them so they become a team with you. A team where you're going step by step towards better vision based on logic and safety. In summary then, I believe the OPD-3 technology not only helps us work on what we call routine cases. You know, I don't like the word routine. Every case is unique to me, but the technology not only helps you do what we call virgin eye cases, myopic astigmatism, hyperopic LASIK cases, cataract cases, but I do believe it also helps another sector of cases which are complex, which could be second opinion cases, difficult complication cases, actually increasing the pool of patients who can be helped with refractive surgery. So I believe a technology which takes little space in your office is at one station giving you so much information that you can take all that information like mathematics and decide which element of the eye is creating the problem, how many elements do you need to correct in single or staged process, bringing the patient again with that desire of best vision potential in every case. So with this technology, I do believe we come the closest we can in today's time to reach that goal. The patients, of course, are very impressed because they're seeing you make a plan designed for their situation. And because you make the plan with them in the room, they become a team player with you. So they, along with you, are desiring the success, and they understand you're doing the best you can as a human being. But using the technology to its full potential is what I would suggest to you as a take-home message from this presentation. Not only to do those routine cases that we do, LASIK and cataract, but take it to the premium cataract surgery cases, take it to those unhappy premium cases who can be helped, take it to those cases who you say no to. There is a way to help them. I appreciate your attention, and thank you so much.